Hello, Dr. Island.
Hi. Hi, Anne.
Hi. How are you?
Yeah, okay.
We're a little early. Do you want to try your slides while you're here? Miss Chetana, are you there?
Yeah.
Is Dr. Himashwata has not joined. When she
You
joins,
see my slides, right?
yeah, your slides are visible.
Fine.
One second, can you just put your slides once more? Once more? Just once more.
Yeah.
Your department, that's a spelling mistake, huh? DPTT.
Department, yeah.
Yeah. Okay.
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 Yeah.
Okay, sure.
So I will be like the second speaker or the third speaker?
Second, I thought I am not going to speak about so much about yours. I'm only going to say respiratory vessel weakness causes this, but these are the pattern of weakness. So
Yeah. That's
three
okay. I'm
examples.
just going to give the cases,
Uh-huh.
and Supriya is going to do the the top up of the data, right?
Yeah, so you're going to give acute and chronic cases.
Yeah.
I'm going to say variable because they present to us in variable shapes and sizes, these children.
Yeah.
When to surveil, when to manage,
Yeah.
kind of thing. I'll try to stick to 15 minutes and finish it off.
Yeah. I'll also stick to 15 minutes.
Okay. And
Yeah.
I will, so part of my overview, I said management. I said I'll not do anything with the management because that'll be entirely yours. I'm also going to try and see if I can share my slides. Visible? Are they visible? Dr. Island? Chetana, can you see my slides?
Yeah, visible, all visible.
All visible. Okay. Great. So then we wait for her. I'm going to try and see if I should rewind Dr. George. Dr. George is there. Do you have Saurabh's number? Can you ask? Anyway, we are on time. Sir, are you there? Dr. George D'Souza, sir? Are you there? Dr. George, are you there? Can you hear me? Dr. George D'Souza, can you hear me? Sir, can you hear me? Sir?
Hello.
Hello, sir. Can you hear me?
Yeah.
Okay. I think we've got all our speakers. No, we don't have Dr. Saurabh with us.
Okay.
Sir, can we see you as well?
A minute.
We have time. We still have time. Hello, sir.
Yeah. Okay.
So thank you so much for being with us. This is a
No problem.
fairly informal session.
Yeah.
We have crossed 3 years, even though this is the 35th session, monthly session.
Okay.
3 months we didn't do in between. So we've crossed our
Okay.
birthday, and next time it will be, we're trying to keep it as very specific to neuromuscular, but there's no
Okay.
neuromuscular without respiratory. So I've not purposely not sent you CVs of anybody because we don't want a lot of formal introductions. I'll just say thank you to ORDI because they are the ones, the Organization for Rare Diseases India. They're the ones who have provided the platform for us this far, and they coordinate, they design, and conduct this. As in, we run a rare disease clinic with them in Baptist, and I believe we're about to start doing one in St. John's as well soon with them.
Okay.
That's a good stuff. Shall I try calling Dr. Saurav? He's the only one that is not here. Did you try calling him, Dr. Supriya? I might lose my internet if I do. Sir, how long ago did you set up the sleep lab in John's?
Sleep lab in St. John's. I think
Uh-huh.
it's around 20 plus years.
Wow. Okay. Okay. And where you were involved in the beginning of it, isn't it?
Yeah, I began the clinic. Now, of course, all our faculty are
All the
trained.
faculty.
Dr. Uma Maheshwari has worked in the UK, if I'm
Okay.
not mistaken, at the Brompton. Uh,
Okay.
and
So we have she's trained. Who's trained in Brompton? Dr. Supriya or Dr. No, Southampton. Southampton one and I
or
think
maybe
Brompton.
Southern, I don't know.
Oh,
She's trained somewhere in the UK.
okay.
And Dr. Kavita is trained from All India Institute, Delhi.
Okay. Okay.
Yeah.
DMD, I
Um,
don't know.
Trying to call.
Dr. Saurabh is the only one that's missing. We usually tend to, this is before time, on time, you have so many people. So usually we tend to give them 5 minutes just to catch up.
Yeah.
So the sequence of events we thought was, I am the non-pulmonologist speaker, the only non-pulmonologist. So I'm just going to say from my perspective, we are the ones clinically seeing the patients. We pick up, our job is only surveil, pick up, pass the ball to all of you. And
Okay.
so Island and her team are the ones who are catching the ball all the time, and now Dr. Saurav as well. So Saurav is also beginning to get lots of catches. So
Yeah.
if they speak from their perspective of acute when they get it and chronic, and Dr.
Right.
Supriya is a younger pulmonologist. She's very well trained, but she's younger to Dr. Island in the sense that she's widely published our data of the number of patients that we have, just a breakup of the NIVs that we've done in the various diseases. So she's giving us, broadly what we're doing. That's the end.
Okay.
This is the
Okay.
sequence.
Okay.
Okay, so only Dr. Saurav. Okay, anyway, just waiting
Calling
for a
him,
few.
he isn't picking my call. I don't know if he has my number actually.
Okay, if I call, I'll lose the connection, but I'll try calling anyway.
Yeah, I just messaged him, but he's not responding to the message. So I guess he's probably trying to get in.
Probably because he was quite anxious about it and he tried calling me multiple times yesterday as well, whether he needed slides and things. So he's very aware of it. Um, I'll try messaging him as well. So we do have some colleagues from the Middle East as well. We have some colleagues from Sri Lanka, the Middle East, and neighboring countries who join us for these sessions.
Okay.
Dr. Himashwita, are you the host?
Ma'am, I am the host, Chetna.
Do you want to hand it over to Himashwita or Ms. Chetna? Are you going to be there throughout?
That's okay.
You'll be there?
Yeah, ma'am.
Okay, so you'll actively see, no, and keep silencing people if they're unmuting themselves.
Yeah.
So Ms. Chetna is our volunteer who coordinates the organization ORDI clinics.
Okay.
So she's kindly staying up with this. Thank you, Ms. Chetna.
Thank you, ma'am.
Yes. Ms. Chetna, do you have Dr. Saura's number? Do you know if he's trying to get in? He's not answering my phone either. Should we? Sir, what should we do? Should we start or what should we do?
Let me try.
No.
ಡಯಲ್ ಮಾಡಿರುವ ಸಂಖ್ಯೆ ಈಗ ಸದ್ಯಕ್ಕೆ ಬಿಸಿಯಾಗಿದೆ. ದಯವಿಟ್ಟು ನಂತರ ಮತ್ತೆ ಪ್ರಯತ್ನಿಸಿ. The number you have dialed is currently busy. Please call again later. आपके द्वारा
His line is busy.
Yeah, something must have happened.
So,
Should we
yeah.
start? Should we
Yeah, I
start?
think, is someone talking to him? If no, someone is not talking to him, then we can start. I think then he can join us in. Send him a
Yeah.
message.
I've sent him a message as well.
Yeah,
I think
yeah.
Dr. Alan has also sent him a message.
Yeah.
Something must have happened. Miss Chetana? Miss Chetana? Chetana?
I think she's on call, ma'am.
Okay.
Maybe she's talking to him.
Okay, she doesn't have his number, which is why I'm a little surprised. Okay. Himshweta, will you keep in touch with Chetana? Do you have his number? I'm just sending you his number as well. So that
Sure,
you can
ma'am.
keep tabs of it.
Sure, ma'am.
Okay, I'm just sending it to you and sending it to Chetana as well. And then maybe we could just start off. Dr. Saurav. Sir, I'm handing over the thing to you. Please, Dr. George D'Souza needs no introduction, has taught many of us, and thank you for coming in today. But I know you first and sir, I know you first and foremost as my teacher and a pulmonologist, who's, as mentioned earlier, who started the sleep lab and many of the interventions. Miss Chetana, Chetana?
Yeah, ma'am.
Okay, just silence people, and I've sent you Dr.
Yeah, ma'am. I'm calling him.
Okay, sure.
Okay.
Okay. So on to you, sir. He's also the Dean of St. John's, and right now, despite the fact that being a super specialist, having set up many programs, from there he's gone up to managing many of us, trying to help us set programs together. So thank you so much for encouraging us and being in this forum, sir. So on leaving the dice to you. Thank you.
Thank you, Dr. Ann, and thank you all for inviting me to moderate this session. I think this is an area which is, which I would say has a lot that needs to be done, because care of people with neuromuscular disorders, whether it is in the childhood or in adults uh, in the community, is quite a challenging thing, and probably there isn't enough that is being done for them. It's only more recently that we've had treatment options which are not only available but are affordable, and we have also understood how to manage these. And I think the additional problem that we have is that we've got in pediatrics, which has a large number of such patients who are also growing up to be adults, and that transition will also require to be done smoothly. We all need to understand what needs to be done, because this is going into the realms of chronic care, and chronic care is always a challenge, particularly in our country where you require to be in touch with the patient, particularly with requires significant amount of monitoring and support, particularly if they have neuromuscular dysfunction. Because as we know, neuromuscular dysfunction, one of the main organs that is going to be affected is going to be the lung, and the lung in uh, two ways. One is the chance of developing infections, and the other one is going into respiratory failure. And infections and atelectasis can aggravate the respiratory failure. Some of these patients might also have cardiac involvement, and that can add an additional dimension to the whole problem. So with these few words, let's go on. Let's listen to the first speaker, and then we'll take it from there. I think it's Dr. Ann, you're going to speak, right?
Yeah. So I'm the non-pulmonologist speaking, giving our perspective of when we come across children with these conditions. So I thought we'll cover the particular pattern of respiratory muscle weakness that we see in various neuromuscular conditions, identifying as a myologist, as a neuromuscular specialist, our job is also identifying the contributory factors. And SDB, or sleep disordered breathing, is a big deal for us in neuromuscular diseases. And we often try to ensure that we have a proactive rather than a reactive approach, and how to do that. So that's some of the things I'm hoping to cover. What I'm not going to cover is what is marked in red: evaluation and management. My respiratory colleagues, I'm very fortunate in the fact that I work with very, very, very well trained, good pulmonologists, both adult and pediatric. They're ably capable of doing these things. So primarily there is respiratory weakness, or the inspiratory muscles involved in inspiration and expiration become weaker in various neuromuscular disorders. There's also added to that, there's impaired cough. And of course, this shows that this goes on to lead to sleep disordered breathing and respiratory failure. Why this is important, and as Dr. George said, many of these people do not walk. They are chronically ill. The disease burden is large, but respiratory failure is the major cause of morbidity, hospitalizations, and mortality in neuromuscular disorders. So just a basic diagram of what we learned in medical school. For weakness, you have your pyramidal neurons that are sending out nerve signals and electrical signals that are intercepted by the motor neuron cells. So if that is the anterior horn cells are involved, you have diseases such as spinal muscular atrophy or ALS. Or if the neurons are involved, nerves are involved, you get neuropathies. Muscles are involved, you get myopathies or muscular dystrophies. And if the neuromuscular junction is involved, you get myasthenia. So this is from a perspective that we have. From a pulmonologist perspective, all of this contribute to impaired ventilatory function. So I'm starting off with one of the prototype diseases, which is in Duchenne muscular dystrophy. I thought I would speak in 3 cases to summarize what we see. So there is about 70 or 80% of the weakness and hypertonia that we see, mostly predominantly in individuals, are non-peripheral nerve involved. They're mostly because of strokes or brain diseases. Only a small percentage of them are because of neuromuscular disorders. So today we are speaking specifically of the PNS diseases. So you can have this is a cartoon to show how I'm looking at the muscle disease. So here we looked at the entire PNS. Anything below the brain from the anterior horn cell onwards is PNS. But here we're looking at only the muscle. There are so many proteins in this cartoon. So try not to concentrate on it. So starting from the basal lamina, extracellular matrix, to what goes on to the sarcolemma, to the nuclear membranes, so the cytoskeleton, and you have if you can see this large straight rod is a cartoon for dystrophin, which is the cause of the commonest muscular dystrophy, Duchenne muscular dystrophy. So you have neurogenic ones such as SMA, spinal muscular atrophy, neuropathies, and you have Duchenne muscular dystrophy, BMD, various limb girdle muscular dystrophies, many congenital myopathies and muscular dystrophies, storage disorders like Pompe, and those diseases that affect the neuromuscular junction, such as CMS, congenital myasthenic syndrome, or even the acquired diseases such as myasthenia. Both of these conditions, the last two, may have acute crisis. Some of the CMSs are absolutely fine, not requiring chronic ventilation, but during crisis may need backup NIV, non-invasive ventilation. So pattern of weakness. Just a quick summary looking at this picture. So if you see the first one, the figure A, you have the classical Duchenne muscular dystrophy. They have proximal weakness mostly. These children, they give us adequate warning. As they have subgravity power, they get progressively getting weaker, progressively stopping to walk, and then upper limbs are involved and axial respiratory muscles are also involved. So that is usually the progression. But occasionally what would happen is they would have upper airway involvement from OSA as well. So your EDMD, these are deceptive, the Emery-Dreyfus phenotype. So these typically, if you look at this, it looks like there's less of the gray coloring on the body, but they would have a rigid spine. If they have a rigid spine, it also means that they're actually quite weak. They end up having restrictive disease. So they can have outwardly they may be walking or not look so weak, but they can be really remarkably weak. Then you have the various limb girdle muscular dystrophies. On last count, there are more than 114 such entities. Then you have the facioscapular humeral disease, distal muscular dystrophies, and those we don't see this in the pediatric age group, the OPMD, the ocular pharyngeomuscular dystrophies. We don't get to see that. So this is taken from one of my teachers, my mentor's papers from the Lancet in 2013, but it's relevant even today. So the SDB is more prevalent in children with neuromuscular disorders, overall reduces quality of life and lifespan, adds negative stress on cardiac health, especially right heart strain, and as we said, morbidity, mortality. So you have sleep-related hypoventilation. They may have OSA, mostly not so much with obesity, but even because their pharyngeal muscles, the entire airway can be so floppy. They have central sleep apnea because some of them very occasionally do have brain abnormalities. They have disordered control of breathing per se. Some of them even have facial weakness. And early on, they often have high arched palate and crowded teeth, which is not helping matters. So they have recurrent infections, prolonged recovery time from LRTIs, and chronic respiratory failure, pump failure. And all of this, I'm going to let Dr. Eilen explain more. So I'm going to start with what is considered, this is something I thought was, heartbreaking. And I'm sure this is a common condition that everybody sees. So this is a 17-year-old boy from a very loving family. They're able to afford care for him. And he comes from a tier 2 city in Coimbatore. He had lost ambulation at 10 years of age because he had not been on steroid. He had not received any standard of care, not for lack of effort on the side of the family, but because they were told, go away, nothing to be done. So he had a cardiorespiratory arrest, but he quickly recovered, and they found that there was no other way other than to entirely bypass his airway and a tracheostomy to allow him to continue. But surprisingly, so he had just subgravity power in his upper limbs. He was weak, lower limbs more than upper limbs, as expected in Duchenne muscular dystrophy. His ejection fraction was pretty good. He recovered, heart was not so bad. So here, what he had was primary respiratory failure, which was not detected. And so we all know there's clinical progression in Duchenne. They stop walking, they stop living. But what we do need to be aware of, while there is reduced life expectancy, this disease that is caused by a lack or absence of dystrophin protein that is encoded with 79 exons, a gene that has 79 exons, where if there is, the commonest being if there's a deletion, so for example here 49, 50, 51 is missing, so there is discontinuity of the reading frame and there is zero protein produced, and that is what leads to Duchenne. So this is again a cartoon of the skeletal muscle highlighting dystrophin. So if this is absent, it is almost like a mechanistic action of a spring of a vehicle, and that leads to breakdown. So this is a normal looking skeletal muscle under histopathology, H&E staining, and this is immunohistochemistry of the dystrophin protein. This is a deceased child's muscle biopsy of a very young child of about 5-6 years. You can see a lot of fibrofatty replacement, and this is the immunohistochemistry, which shows hardly any dystrophin protein. And this is a milder phenotype of Becker, where while this is not same as A, but it's still not normal, and there is some amount of dystrophin that is distributed. So this is progressive disease. So there is no cure so far we know, but there are newer cures coming. But even without these curative disease modifying therapy, we have a national average that is published by our Apex Institute, which says that the average age of survival is 15. So I have also seen children who have succumbed at 10, be it cardiomyopathy or be it respiratory. So, but other countries like Western countries or more resource-equipped countries like England has data which says 39 is their average, and France has got a 42 average. Oldest person more than a decade ago survived till 54 with just supportive care. So the answer is, while we are chasing cures that are aimed at replacing dystrophin or newer agents, the standard of care is what is underpinning the survival of these individuals. We had regularly had patients who were surviving post their 40s. So this is showing that the natural history of Duchenne, the current reality has changed. So we are still stuck earlier. So the spine surgery and ventilation was the norm in more Western countries. Now they do not have that much with very good steroids and cardiac management and respiratory care. We're finding that the scoliosis that makes it so much worse we can obviate or even prevent scoliosis from happening. With good bone health management, we can totally prevent scoliosis from setting in before the 18th birthday when bone growth is complete, or skeletal growth is complete. So some of the things that we ask, we see ourselves as the gatekeepers to our pulmonology colleagues. So during routine follow-ups, when we see our children with these conditions, we always ask them. Regularly they would refuse and say, "Oh, yeah, I've got no problem. I've got no breathing problem." But we ask them specifically, "Do you have preferred positions? Do you have frequent position changes? Do you have daytime sleepiness, snoring, early morning flush face, and early morning headaches, reduced appetite, and weight loss?" So by the time reduced appetite and weight loss is setting in, it's usually quite bad. And so multiple fragmented sleep. So this is an important question for us because increasingly our patients are surviving and they're no longer within the remit of us pediatric practitioners. So internationally, the entire community, the neuromuscular community, is going towards. So this is one of the consensus guidelines on how to manage older surviving people with Duchenne muscular dystrophy. And we are still, so to conclude, so this is an algorithm that we had presented together on how to manage children with a typical neuromuscular disease, which is proximal weakness. And in a country like ours, where we have very few centers which do level 1 sleep studies on how to, we have a way of, a higher level of index of suspicion, how to just start off with if we thought it was eminent respiratory failure, already an established failure, even without waiting for sleep study, to start them off on BiPAP, allow our pulmonary colleagues to blindly start titrate later and then come back for titration studies, so that we're not wasting time. So this is another case. This is a different scenario. A second child who's a 9.5-year-old. She presented to our unit at 9.5, but so this is not a picture of that same child. This is a picture of another child with a similar condition whom I had encountered when I was in training. So at birth, she was noted to have arthrogryposis multiplex congenita. Her CPK was elevated, but not in the severe dystrophic range. She looked so terrible, and the reason I put these two pictures is she's not so terrible. Children with these conditions don't get so bad. They usually get a little bit better. As you can see, this child is less contracted. This is the same child at birth who has looks less deformed as the child has aged. And so she was diagnosed with, on muscle biopsy, of having reduced expression of the collagen 6A protein. So genetics was not done, and the parents were told, "Look, there's nothing to do." So she walked, and the parents were spent the rest of their life trying to see how they could get this child to stand and walk. But what was not recognized and what we failed to do was that warn them that even if she's walking, this is a disease with disproportionate involvement of the diaphragm. So she presented while she was in a small town away from Bangalore. They're from Bangalore. The father is in the CRPF, and she just collapsed and she was very drowsy. They took her to the local hospital where they gave her oxygen. She worsened. She became increasingly comatose on being given O2.
हेलो। हाँ, थोड़ी देर के बाद बात करो, एक मीटिंग में हूँ अब, ठीक है?
Hello, am I audible?
Yeah, you're back.
Yeah, okay.
Yeah.
Okay, sorry. So this, after she improved on starting BiPAP, and so she just woke up after, her CO2 was some 82 something, and gradually she improved stabilized on BiPAP. And diseases like collagen 6 related disease are notorious for causing diaphragmatic weakness, disproportionate diaphragmatic weakness, even in walking individuals. So this is a cartoon of collagen 6. I don't wish to scare you with all of this, just only look at the collagen 6. So this is a disease which has a spectrum, like anywhere from Bethlehem's, the milder end, to the Ulrich, which is the more severe end. So some, just showing a picture, not showing anything else. LMNA, this causes rigid spine. So these children look like this. They have restrictive disease. So these children they would have a slightly different involvement of the respiratory weakness. So as of 2021, we have more than 114 entities, newer genes, same genes, different phenotypes have been described. So those with more cardiac involvement, not everything has cardiac involvement, but invariably everybody has respiratory involvement. So the last scenario is a little girl who has spinal muscular atrophy. So she presented in 2018. This is before the era when we were able to have access to disease modifying therapies. She presented, she was the only child of her parents. She came to our PICU with severe pneumonia, severe failure to thrive, recurrent chest infections. And now, at that time, given to us, we gave
Okay, now she has fever. So,
we gave her supportive care. So this is to give a flavor for the types of SMA. Now, even before disease modifying therapy, type 2s have variable lifespan. I remember being told by my mentors that type 2, if they did not survive, it was our failure. We had to be able to keep them supported and they could live. Type 3A, B, and 4, they have normal lifespans. But I have often come across families where even type 3s have succumbed.
You're again gone offline.
She had type 2. She had type 2. And what happened was just giving her BiPAP made a huge difference. Then, because of the failure to thrive, the family was willing to listen. We gave her a gastrostomy. And that really helped prevent her from getting into ICUs. And this is her getting in 2021, she was able to get the disease modifying therapy, Spinraza, through the Humanitarian Access Program. And after that, she has further improved. Despite being on this, at age 6, she had an RSV bronchitis and an chest infection. She improved, was discharged after a week, but she collapsed at the end of it because she was not able to clear her secretions. At that time, we did not assist. This is the year 2021. We did not have access to cough assist, so we were able to get our hands onto a cough assist. We had no ventilators in our PICU at that time, but we couldn't send this child away. And what we did was almost every cough assist and nebulizations. By morning, she was fine. By the next day, she was discharged home. Since then, ever since, cough assist has been part of, this is not exactly rocket science. Most Western countries have these equipments, but we struggle to have access to these. So to summarize, there are many treatments for SMA, gene replacements, and treatments which make SMN2 more efficient, such as nusinersen and risdiplam. But the underpinning it of all is the standard of care. So far, we have over 600 children who've with SMAs, but only 80 plus have received disease-modifying therapy. These are all the various drugs, children who received the drugs, 34 gene therapies, nusinersen and risdiplams, but 700 plus getting BiPAPs, 13 plus etiplursen. But what I'm a bit more embarrassed and what we are aspiring to is that we've given crores worth of medicines, but we are not able to afford 4.75 lakhs worth of cough assist. In other countries and more resource-equipped countries, every individual, even if they have access to a therapy or not, has their own cough assist. I hope this will be our aspirational way of getting it done. We have two children. These are the two DMD therapies, Darsen and Atalurin, that our patients are getting. So to take home message, NMDs are becoming increasingly treatable and manageable. Early recognition of respiratory involvement helps manage and preempt hospitalizations and life-threatening events. Each NMD has its pattern of involvement. Hence, the importance of MDT and liaison between especially the neurologist and the respiratory physician. And NIV and ventilation is the cornerstone of management to improve survival and quality of life. Complications almost always predictable and hence preventable. Thank you.
And for that interesting presentation. I think one of the important things that you made in your opening remarks was to be proactive, and proactive in two important areas. One is proactive with respect to when to support the ventilation, and the other one is proactive in terms of being able to help the patient clear up the secretions. And you gave very livid examples where both these both these problems were addressed, but took some time to address them. So I think going forward, what we are looking at is how to address when the patient should be ventilated and how we should address and maybe even train the family to be able to help the child or adult clear secretions. Um, I think that's all I have to say at this moment. We listen to the next speaker, who I presume is going to talk about some of these aspects that I have spoken about.
Am I visible?
Yes,
Audible?
yes.
Yeah. Thank you so much, sir, and all the esteemed faculty, my dearest friend Anne, and all the people listening in. I know they're predominantly neurologists here, but at the same time, I think we share a very common field here. And Anne has already given a introductory message about respiratory care and its importance in NMD, and I'd like to talk a little bit more and share our experience. So we go through case presentations because I think that's another way of, imbibing and learning more about the cases that we had that were challenging, and we learned from them as well, right? So we have a child who is born third degree consanguinity, never had an ICU stay, had delayed motor milestones, at 9 months was diagnosed with type 2 SMA, received the gene therapy in June of 2021, guided by Dr. Ann and the team at Baptist, and BiPAP was initiated. But the child presented the same year, few months later, with severe respiratory distress secondary to aspiration. So we did initiate the BiPAP, but the family was not compliant. And because they had received the gene therapy, they also felt that, now the child is just better after the drug. And, everybody, the family thought that, all these things will not be required. So they came in very sick, very severe. So we had the child on the BiPAP, and we tried every possible way in the ER to continue with the BiPAP, but she really required intubation. And finally, she required a few days of ventilation, and we had to take a decision to do a trach because she had already a bell-shaped chest, a pectus, as well as she was really a lot of secretions drowning our airway and recurrently aspirating. And that's also, and failure to thrive was another one. So we had to peg and trach at the same time. So we in the same setting we did that, and the peg fundo was done in that same year of the after she received the gene therapy, and this was a type 2 SMA. So she's been on BiPAP post tracheostomy. She bought her own cough assist, and you can see her here with the tracheostomy and the BiPAP machine connected and all these suction apparatus. So we trained them with the tracheostomy, trained them with the BiPAP machine, the suctioning, trained them with the PEG fundo finally, and also the cough assist. They bought their own cough assist, and we managed to send them whole. She did have some recurrent admissions post gene therapy, the tracheostomy. Then she had some tube block because despite of our intensive training in tracheostomy, blocking and removing, she did have a full tube block and through a seizure. And there were some problems with the suctioning at that time. And subsequently in December 2023, a respiratory tract infection, a otitis media brought her. And we've also been doing regular titration studies of a BiPAP with a tracheostomy or sleep study has been going every year annually. We're doing it. This is her now. She has gained a lot of milestones in terms of neck holding, and she's also vocalizing, singing, and she is doing quite well.
ಏನು ಎಲ್ಲಿ ಮ್ಯಾಪ್ ಕುಂದಿರುತ್ತೆ
Yeah. So this is now, she's practically almost 4 years post gene therapy, and she's doing otherwise.
ಏನು
So she gets a break of the ventilation, usually half an hour to 1 hour during the day, intermittent breaks. She continues her nighttime BiPAP. She's not had any respiratory tract infection in the last 18 months. She's had a good weight gain, and her parents are very conversant with the cough assist and BiPAP. The challenges, of course, we had were that she received gene therapy, but there was no BiPAP pre-gene therapy. Also, the parents were not willing to fundraise for the same. They were not willing to go on social media sites for the, even funding for the BiPAP. The family was very reluctant. And we also understood that, a SMA child requires MDT, including the neurologist, the pulmonologist, the gastro, the physio, social worker teams, nutritionists. So it's a whole lot of teams. It's just not one team that has to manage, multiple teams have to get involved. And of course, in a critical care situation, the ICU team is definitely involved. We have another child who's a 3-year-old. She's a triplet. She was born preterm. She had distress at birth. She had a few days, 16 days of NICU stay. She had a developmental delay, and she was diagnosed at 1 year, at 7 months. And she had already had 4 episodes of pneumonia, which required ICU admission. She also had some aspiration pneumonitis, apparently at 10 months, treated with HFNC, nebulization, antibiotics. They are from Kerala. And then finally, the parents had to we had to do a green corridor and shift her quickly in an ambulance to our hospital. And she had fever, she was distressed, she was requiring oxygen. We initiated BiPAP, but she still continued to have lots of apnea, bradycardia, requiring bag and mask ventilation. We did a sleep study during that time as well, and it showed multiple apneas and hypopneas. And this is the father who has been trained to do the cough assist. So he's So PEG and fun. So this was another child, very similar, recurrent aspiration, pneumonitis, 4 ICU admissions. So we could not extubate her. We had to trach, and we had to do a PEG fundo at the same setting. Then weaned her off on oxygen and BiPAP. We started a cough assist in the hospital, and again teaching the family for the how to use the cough assist, how to manage the tracheostomy, suctioning, and all this was done. And she went back home safely. She also started Ristiplam in November 2021, because by the time she had already crossed her 2 years and they couldn't raise enough funds for the gene therapy, right? So this is again. So she's comfortable with the BiPAP on the tracheostomy. So she's doing pretty well, singing along, even with her tracheostomy tube. But we did have a lot of challenges with her. She had recurrent admissions. The 2022 March was the tracheostomy. She had a tube block, hypoxemic seizures. Early Jan 2023, she had a respiratory tract infection. Again, in May 2023, she had some respiratory tract infections, but all of them she required no ICU admission. She also had a liver abscess that was out of the blue. May 2025 was the last pneumonia, but she was quite well for a year, and she's not had to be she's not had a very sick or severe episode requiring prolonged, ICU stay. We have been consistent with her BiPAP titration and her sleep studies. So this is her. She's one of the triplets. She's the one with the SMA. And now she's on Risdiplam, gaining weight. She has a little problem of a scoliosis, which have been worsening. She has a lot of a gain in the milestones, and she regularly uses her BiPAP, mostly nocturnal BiPAP, and more breaks in the daytime, and using a cough assist daily. Of course, this has been a very motivated family, and they have been, able to, both the parents have been able to hold the family together and take care of this child. We have a third child who is basically a child with no recurrent chest infections, just a history of snoring, mouth breathing, a typical sleep disordered breathing kind of history. He's a 13-year-old boy with a DMD, was on steroids, wheelchair bound since he was 9. The sleep study was done in 2023 when we first met this boy. He had done multiple PFTs, which were all normal. So when we did the sleep study, it showed 30 obstructive events, 69 hypopneas, and a total of 99 events, right? So significant number of events, despite the fact that he was just a well child, doing well on steroids, wheelchair bound. He had no past history of recurrent infections, and also just a bit of snoring, mouth breathing. He had a little bit of restless sleep. We initiated this boy on BiPAP. And apart from that, we are also doing the transcutaneous in our hospital. So his early morning TCO2s were in the range of 57, 55. So this is an additional thing that we picked up, despite the parents are not going to obviously give us a history that he's hypoventilating. And if at best, some of them might be saying he's a little bit tired, sleepy. Some of them may have headaches with the CO2 retention. But this child didn't have any of those symptoms, and he had a clear-cut hypoventilation that was picked up by the transcutaneous. So this is this boy now using his BiPAP. So important thing to note, especially the RDMD boys, are they well and they may not have any symptoms. And most of the time, the nighttime hyperventilation precedes the daytime symptoms. Before the overt symptoms patients come to you with, and may be only identified on the sleep study. And the PFT may not be a true marker of what's happening at night. So this is typically what happens to our ambulatory, early non-ambulatory, and late non-ambulatory DMD patients. In the early ambulatory or the late one, we are still going to have sleep-related breathing disorder, either due to tonsils or obesity. And of course, the pharyngeal muscle weakness contributes to the OSA. Their muscle power starts decreasing, especially the inspiratory muscles. And so they have this low volume, low strength cough, and then any viral can tip them off and increases the risk of pneumonias. As they become non-ambulatory, all this worsens along with the worsening of the thoracolumbar scoliotic spine, and the cough becomes even worse. So the hypoventilation begins, and usually it's seen first in the REM sleep, and then later it progresses, and the spine, the low volumes, all this entire thing worsens the OSA, and these children rapidly progress to hypoventilation. So these are very important factors in a child with, especially with Duchenne's muscular dystrophy. We have an 8-year-old boy who's got Duchenne's muscular dystrophy, has started on BiPAP on just very minimal settings, uses only at the nighttime, and he developed he was actually initially not very compliant on using BiPAP, and he has problems with not sleeping well, recurrent awakings, some kind of headaches. The child started complaining, and he was admitted with increased work of breathing over the last 10 10 days, and he was brought to our hospital. He was tachypnic, saturations were almost 80% on room air, poor air entry laterally, and he had no cough, no cold, no fever, no respiratory tract symptoms, literally. He had a mild pH on the echo, and we obviously increased the BiPAP pressures before starting the child on oxygen, and we did a sleep study, and then we titrated him subsequently. If you look at his X-ray, you can see this part is completely collapsed, the left side. This also, it just shows very low volume lungs. And on the day of admission, this is like completely, whatever was there in the previous X-ray also, this is like kind of, the lung is completely collapsing. And this explains the reason why he came in with difficulty of breathing, low oxygen, and all we needed to do was increase the BiPAP pressures, change the settings from 9/5 to 14/5, and also help him with the cough assist. So this is him. And, so this was the follow-up X-ray. You can see all this has opened up, and this was just within 2 days. We took him into the ICU, but he never required any ventilation, intubation, bronchoscopy, or anything. We just increased the pressure settings of the BiPAP. We gave him 2 days of good amount of cough assist, and he got remarkably better. So like Anne has explained, the referral pathway in our unit, in the units that we run now, is the pediatric neurologist or even the adult neurologist would be the first one seeing the child. We may have symptoms of overt symptoms of sleep disordered breathing. If it's yes, obviously we're going to ask for a sleep study and then initiate BiPAP or necessary PSG. If it doesn't, then if he doesn't have, we still have to look for other things like failure to thrive. Is the child having swallowing difficulty, hence aspirating, subgravity shoulder power, recurrent respiratory infections, PICU admission, any invasive ventilation, any other pathology like the col6 case that Dr. Ann just discussed with us, poor lung volumes, very difficult in smaller children. In the SMAs, even much more difficult. Loss of ambulation in the DMD kids. So even in all these things, we preempt and we usually start them either on the BiPAP or get the sleep study done as early as possible. The last case, we have a child with 11-year-old with a central core myopathy, very worsening scoliosis, very slow eater, difficulty in swallowing, so she had a dysphagia, no coughing with feeds, very weak cough, no obvious history of sleep disordered breathing, no recurrent history of chest infections. Was sent to us by the spine team. We started the child on BiPAP pre-operatively, and this is the last year they had done. This was a pre-surgery spine X-ray. You can see she really has a bad spine here. In August 24, this was what they had done with the rods that can be, manipulated as the child grows. And this is in May 2025. We can see at least the lung volumes at least look better, both sides. And she is a child that is doing pretty well. So what we did was we gave NIV before the procedure, the scoliosis surgery, at least 4 weeks prior, also post surgery. We also used the Liam, the new Prisma machines with this insufflation, which is like a cough assist to help clear secretions. A lot of physio nebulization with the pain management and good multidisciplinary care. So this child also did not go into the ICU, did not require intubation, ventilation, didn't have a long collapse after the surgery. She gained weight and height as well after the surgery was performed. So we are now again running a neuromuscular scoliosis program in which when we see children when the spine surgeons see children with neuromuscular scoliosis, they refer to us prior to 4 weeks prior to the surgery. Apart from wherever possible, the spirometry, any other extended lung volumes or DLCO if wherever indicated, sleep study wherever possible, blood gases to check especially for the carbon dioxide or the TCO2 levels. And then if we know that the child is high risk, neuromuscular, severe Cobb's angle more than 90, very poor lung volumes, sleep hyperventilation, then we have to be extra careful. The low risk ones, no neuromuscular, non-severe, not a severe scoliosis, good lung volumes, no sleep hyperventilation. We are not really worried about these patients, but this really is a category that we have problems with. And so we are preempting, starting them early on the BiPAP, at least for 2 to 4 weeks pre-op. And then also we prep them that post-op, if required, PICU. And of course, we start them on cough assist as soon as they come out of their surgery. So so even if they are at less risk, most of the time now we are starting NIV 2 to 4 weeks prior to the surgical intervention, and or depending on the case. But these are the ones that are just very low risk. The high risk ones, we immediately start them on the NIV and the cough assist post-op. Yeah. So post-op, again, we continue on the NIV. And if not on the NIV, we extubate in the OT to NIV. We continue the NIV post-op and then change to all this, the cough assist or the Liam machines, rigorous airway clearance and pain management. And additional support. If there's any evidence of lung collapse, we're starting the cough assist early, continuing NIV post-op at least 2 to 4 weeks. No collapse, no events, then we still continue NIV for 2 to 4 weeks post-op, and then we follow up. So these are some of our heroes, the triplets, the SMA child that I showed you. This is our SMA child that has reached IIT Indore. She has joined last year. She's had a spine surgery. She's been with Dr. Ann and me for, I think, the last 10 years. This is another boy. He turned 32. We first met him about 11 years ago. He was told that, he's just going to deal with it. He had difficulty sleeping, and he was, not able to sleep. But we got a sleep study done. He had a lot of events. We started him in BiPAP. He works as an engineer in SAP, in the SAP labs. He just completed 10 years. He's bought his own car. He takes care of his mother. And this is our ORDI family with all these kids that are all predominantly neuromuscular. So thank you. I'll just end my talk here and see if there are any questions.
Thank you, Dr. Aileen,
Thank you.
for that interesting presentation. So, when you see a patient and who's not yet symptomatic, I mean, because basically what we are looking at is proactively dealing with the impending respiratory failure, and also to be able to help them uh, clear their secretions. So, what would you recommend that be done so that you can identify those people who require more attention to these problems, like initiating them on BiPAP
Yeah.
or on cough assist, or physiotherapist, or whatever it is?
Yeah. So I think the key factor is, like the DMDs may not have any overt symptoms, but the minute they are non-ambulatory, their subgravity muscles are not working, we advise for sleep study. The sleep study most of the time, 99% of the time, picks up events, and then we initiate BiPAP. It also gives us an objective way of telling the parents, like, look, this is what's happening at night, because sometimes parents do not. They say, my child is okay, he's on cardiomyopathy, he's on steroids. But most of them are also by the time on steroids, obese, OSA, so multiple factors. So that is one. Doing PFTs again and again, some of these kids feel that, the PFT is normal and they are fine, but they are not able to compensate at night. So that's why sleep study becomes so important. The other factors are the SMAs, where they have recurrent respiratory tract infections, aspiration, pneumonias, lot of problems with their respiratory functions, and they already, or some of them come to us failure to thrive, pectus is already there, and aspirating, poor feeding and swallow. So those we do not even wait for the sleep study. So most guidelines say you can initiate BiPAP as soon as possible and get them to do the then sort out all the swallowing, the NG feeding, the PEG fundo. So there are two different categories here. Apart from that, like Dr. Ann mentioned, the call six, the kids with the diaphragmatic paralysis, some of them come to us in a full respiratory failure, where the hypoxemia is the hypoxemia is what brings them in. But actually, we just need to give them the pressure support, and even that hypoxemia is eliminated. Essentially, they come to us with high CO2s, but it's reflected as low oxygenation. And those are the patients that we have difficulty sometimes, that somebody gives them oxygen, it cuts off their drive and they go into a CO2 narcosis. So these three category of kids, the SMA who come in with aspiration, recurrent failure to thrive, the DMDs that are well preserved, but we need to preempt and get the sleep study done as soon as they are non-ambulant, or follow them up subsequently. And the third type is where diaphragmatic or atypical presentation comes in, right? Some of the other way we also look at, some of these kids have no neck control, right? They may be having some swallowing deficit, or oropharyngeal muscle weakness. Those are the ones definitely, if your oropharyngeal muscle weakness is there, most likely even you have a respiratory system that's not going to hold on for too long. So those are the other clinical clues that we look at. Transcutaneous wherever possible, or even a venous blood gas or ABG may also help, because some of these kids are hypoventilating early morning when the compensation is not happening. So if we don't have a sleep study, at least VBG, a blood gas, these can also be done. And 90% of our neuromuscular actually do not, I would say, do not come in with sleep disordered breathing. Very few. It's really the really long, like, the older DMDs come in with the headache, the mouth breathing and all this. So most of them don't even give us the history that they're having some difficulty with the sleep and all those issues.
So what you're saying is that a sleep study should be done as early as
Ideally,
possible.
as early as possible. So
Okay.
that's the gold standard. It's a standard of care, and it also picks up very early, much early. Like the case that I presented, he was 13 years old, no features of anything. He just had he when we did a sleep study, he had 99 apneas, and also his carbon dioxide was 57, 58. And by the time we see them later, if they have a respiratory infection, they're going to go into a frank respiratory failure. Any infection is just going to tip them off into respiratory failure. And by that time, it's quite late by the time we get them to do NIV or anything else. Yeah.
Yeah, Dr. Saurabh is, I believe, there. Dr. Saurabh, do you want to add anything?
Yes, sir. Good evening.
Good evening.
Yes. I mean, almost of the things have been said. So basically, I would just like to, in a short nutshell, the thing is like these kind of children have basically the problem revolves around three things. First is the weakness of the respiratory muscles. Second is the sleep issues, which is again in part to contributed by the weakness of the muscles and ineffective cough. And how to tackle with all this already, Eileen ma'am has said. But uh, other things we should not forget, apart from the respiratory management, there are other organs which also have a role in the respiration. Means like taking care of the cardiomyopathy, a good nutrition support, as well as regular vaccinations and immunizations. And also we should also uh, the other part like bone health, which is again a very important thing, because the 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 I mean the nutrition as well as the bone health also in contributes to some extent by the respiratory muscle I mean the respiratory muscle functioning in a way. So that also needs to be taken care of. And early initiation of NIV is very important, because that helps in offloading, or basically the deloading the load on the respiratory muscles, which starts very early. And as ma'am very clearly said that, since I mean, the PFTs, the biggest challenge with the PFTs and the other tests of the respiratory muscle strength assessment is they all are patient effort dependent. And most of this, especially what we face problems in children, that they can't perform. So ideally, though the books say the FVC less than 50% coincides with the alveolar hypoventilation, but that doesn't comes holds very true in pediatrics. So that is why a sleep study is very important. But if we don't have access to the sleep study, but clinically, if we say that seeing some chest deformities, or even like unable to raise arms above the head, so some common bedside tests we can do, so that we can see, which basically tells about that the diaphragm is already involved. So we should not wait and start them on BiPAP as early as possible, because earlier we start, maybe the child will do better only with the nocturnal BiPAP. I mean, the night time. Daytime may not meet. More delay, it's there, the child will require most of the daytime. And again, in children, the challenge is most of them in daytime or in the awake state, it's very difficult, because going to school and other things, they will not keep the BiPAP. So that is another very important point. And other thing is that if it is a BiPAP, not only from the improving the respiratory muscle strength, it also like helps in improving some of the, I mean, the basically improvement of the some of the chest deformities like scoliosis, because some of them, when we by the time they reach to us, they already have developed some chest deformities, especially like scoliosis. So to some extent, it also helps in improving their scoliosis. May not be completely, but yes, it helps. And also especially when these children go for any surgical procedures by orthopedician or any orthopedic procedures. We before giving clearance, most of the times they are being referred to us for giving clearance. So before giving for clearance, we should always assess the respiratory muscle function bit, and if it is there, definitely we should plus preemptively start the BiPAP NIV in different forms, and after that repeat a sleep study or titration study. How is there is an improvement of alveolar hypoventilation? Then only should give clearance for surgery, because to avoid any mishaps or whatever, to avoid any adverse events in the OT. So there should not be any hurry for the surgery or giving clearance for the surgery.
There's a question there about if the sleep study is normal, uh, are we safe? And if the sleep study is normal, how often do we do the sleep study? Because doing sleep studies is a much more longer process. I mean, it's not something like doing an arterial blood gas or a spirometry. You can do as many as you want. But, and if I'm not mistaken, the number of facilities that do, of course, there are these fly-by-night operators who do sleep studies. But if you want to do a proper sleep study in a hospital with a level 1 sleep study, the facilities that are available are far and few, and someone to interpret it. So, if how often would you do a sleep study?
So unless if the child is symptomatic, definitely. If not, we also screen annually. And for the DMDs, definitely if they are non-ambulant, that's the time when we do it. If it's
And
normal, you don't need to
yeah.
repeat for another year.
Okay.
Just the annual study is enough.
So that's actually one of the studies. I think Shruti, I hope that answers your question.
Because in
The,
DMT
the other
guidelines,
second thing that I want to know
sorry.
is, I mean, I think this is, like I said earlier, is it's a chronic disease, it's a chronic difficult disease, and we really need to have the parents
Motivated.
actively involved in the care of the patient. So, how do we how how do we involve them, and what do we do?
So I think that's the biggest challenge because some of them, find it very difficult and challenging. But I think over time, at least Dr. Ann and my
Okay.
we've put them, most of them are in DMD or SMA support groups, right? So like SMA Karnataka group, SMA Tamil Nadu group, or All India SMA group. SMA 1 groups are there, SMA 2 groups are there, DMD groups are there. So we also identify amongst our patients and patients' parents who would be a good advocate to help another parent. Like say somebody is from Tamil Nadu. I know I have a patient whose parents are fairly well versed and able to counsel another family. So we also connect them together and tell them, please help with this family, understanding, managing what is the long haul, what are the costs involved, because everything that a doctor says is very difficult for them to follow because the
Okay.
challenges are immense for a chronic neuromuscular child, right? So that's
Okay.
that. So I think a parent supporter group for
Yeah.
us been the biggest, advocacy factor here. Yeah.
Okay. One more question before we move on. Uh, what is the threshold, or when will you advise a cough assist device? Because as someone said earlier, I think Anne said it's such an expensive device and it's not so easily available. So when would you
Advice.
advise a cough assist device?
So see, I think children, especially the SMA ones, they're chronically aspirating. Even if you do peg fundo, they're still aspirating from above. Salivary aspiration is there. Their lungs get flooded. They're not able to clear off secretions. So
So
most.
would you use simpler things like anticholinergics, like maybe tiotropium
So I
or
think all those are really temporary. Most of these kids need the cough assist on a daily basis. So I think in our cohort, 18 kids have bought the cough assist, and especially the ones who have received the expensive drugs. After having a 16 crore drug, if your child is still going to aspirate, then you are more prepared. So most of our children, they do, the ones especially that receive the gene therapy, most of them have bought it because it is cost effective. It avoids recurrent hospital visits, recurrent pneumonias, recurrent aspirations. So we have a lot of kids using that. We have also started, so Anne and me, we also have a team that have put a rental service of this cough assist, because for 2 years there was no cough assist manufactured by any company. So we told the vendors stop selling it. There were two last cough assist machines. So you say a patient needs this for 10 days, 20 days, 30 days. So especially within the vicinity of the city, we have these cough assist machines. Of course, we are sterilizing it, following the protocols. And especially during the flu season, the October, November season, we have a lot of our kids, SMA 1s, 2s, DMDs also, they require this cough assist because any respiratory infection, the load, they're not able to take it. So we have put this on a rental system. I think it's nowhere in the world, it's nowhere in India, but we have done it, and it's been going on for the last 4 years, the
Okay.
offices rental system. Now
Okay.
there are two companies that have launched in India. The Philips stopped manufacturing. There's a company called Byways and Brias. They have launched two machines in India in the last 6 months, and they are very expensive. And we are also talking to them that, we have to get, because it is much more expensive than a BiPAP machine, right? And we
Okay.
also have to convince parents to buy it or to rent it in a way, it has to be cost effective for them as well, right? So I think a little bit of a struggle there. But in Bangalore and the vicinity, all our kids have access to this system because it's a rental system.
There's a question probably to Anne. Can we recommend exercise to these children, or should that be avoided?
Shall we finish the last talk is very short because I
Yeah.
want
Okay.
to add to the answers that Dr. Aileen has given. I was restricting myself.
Okay.
It's
Okay.
just a summary of what we are doing.
Okay. Can we go to the next speaker, please?
Hi, just getting my video on. Hi. Is my screen
Yeah, can see it.
visible?
Yeah. But can you go into for the full screen mode? Yeah.
Is my screen
Presentation mode if you can, otherwise you can carry on. It's visible, it's visible.
okay? Yeah. So hi, I'm Supriya. Good evening, everyone. It's in the it's in the presentation mode, sir.
So
Yeah, yeah. It is in
it's in
presentation
the
mode.
slideshow, no problem.
So I'm
You can carry.
Supriya. I'm a pediatric pulmonologist and sleep specialist at Manipal and Bangalore Baptist Hospital. And today I'm going to talk on the home mechanical ventilation and sleep services that we have. I want to thank Dr. Anne for giving me an opportunity to talk here. And I want to say that I was a resident in 2019. I was a resident in 2019 and 20 with Dr. Ali. I used to go to the NMD unit every Thursday happening at Baptist, and that's when I met Dr. Anne. And like someone mentioned in the talk that, it's really inspirational work, and it inspired me to go to Southampton to pursue pediatric sleep medicine. And I came back to Bangalore in 2023, September. I'm going to talk about the growth of the pediatric sleep and HMV services that started. I'm going to talk about from 2012. That's when Dr. Eileen had the new sleep lab in Manipal, and there were about 3 to 4 PSGs that were done, level 1 PSGs that were done every month. So this is per month data. And about 4 to 6 new BiPAP initiations is to happen. And this continued till 2018-19 when the NMD unit and the number of PSGs and the BiPAP initiations doubled. And last year we had about 15 level 1 PSGs that were done in about per month, this is, and about 10 to 15 BiPAP initiations that happen per month. And the numbers are more this year because we've also started our sleep lab in Baptist Hospital. So out of the total sleep studies that have been done, these are done for the children with neuromuscular disease. And this shows the burden of the neuromuscular disease that is there. And from our NMD unit, we've got more than 900 referrals to the pediatric pulmonology department. And more than 700 children have been initiated on home mechanical ventilation. Of this, 5% of them are on tracheostomy. About 15% of them have alternate feeding technique like a NG feeding or gastrostomy. And use of cough assist devices, again, then 15% of them. So out of the 62 children who have used cough assist in the last 3.5 to 4 years, 18 of them have their own device, and others use it on basis, like Dr. I mentioned how our system works. And on follow-up on our data sheet, we have about 420 children. So these are children that we have seen at least once in the last year or via video consult or phone calls. Sort of these 420 children on our database, the cohort have SMA 1, 28% SMA 2, and 11% SMA 3. So you see that SMA is the largest cohort, and 22% of them have DMD, and 27% fit into the other neuromuscular disease. And for out of the 423, 26 children had all these comorbidities that the data was available for, and about 70% of them had a history of sleep disordered breathing. About more than 50% had recurrent chest infections, about 60% of them had bulbar weakness, and about 30% had scoliosis. So you see that all sleep disordered breathing or a recurrent chest infection. And this again, it brings about the fact that doing a sleep study is very important for children who might appear asymptomatic. And we looked at the outcome measures 1 year post BiPAP. So we had data for about 36 children, and more than 75% of this cohort had an improvement in sleep, decrease in recurrent respiratory tract infections, and decrease in hospitalization. And 26 children had expired from this follow-up. So the HMV system our unit is like the referral pathway both Dr. Anne and Dr. Eileen have spoken about, which is in place. And then the multidisciplinary pediatric gastroenterologists, surgeons, ENT, and the dietitian, all of them are essential part of the team. And a lot of times we get asked questions that where do we initiate the BiPAP, or the BiPAP initiation, where is it done? So the child is presented in acute with acute distress, and then are initiated on BiPAP in outpatient, in OPD, and after a mask fit. And we always provide a written plan for BiPAP and the cough assist settings, the tracheostomy care, along with plans for escalation and care. We also, like Dr. George mentioned in the starting, that a continuous support is needed for our patients. So we provide our phone numbers to almost all patients, because they'll go to a peripheral hospital, and then they'll be like, oh, the child is having decrease in oxygen levels, and they'll stop the BiPAP and gives the child oxygen. This happens quite often, actually. So it's very important. We've realized that to give our numbers to the families. And there's 24-hour respiratory technician support that is given. And our technician also visits the home locally for any troubleshooting that needs to be done. This is in Bangalore. And what has really changed, I think, the BiPAP device that was available. So the earlier it was like 2-3 lakhs, and now it's come down to 45,000, approximately, the most basic model. And even Philips and all have about 80,000, up to 80,000, 70, 80,000 rupees. The machines are available, and this has made it accessible for most of our patients. And I think this also changed in about the time of 2018-19, and that's why we're able to put more and more children on BiPAP. And this is the referral pathway that Dr. Eileen and Dr. Anne have spoken about. The cough assist we've been using for the last 3.5 years, and it's generally started in children with poor cough reflex and recurrent chest infections. Ideally, it would be there are 18 patients who own the device, and 10 of them use it daily because they see the difference. The other patients, because it's expensive, who can't afford it, they want to develop. There's symptoms that are there, so they ask for the cough assist device to be rented. And we realize using the cough assist decreases their duration. Dr. Eileen has mentioned that we use it quite often. So what has helped us is the rental service for the BiPAP. The advanced come with the lung inflation assist manual. So LIAM is lung inflation assist manual. It doesn't have that expiration pressures, which is there in a cough. It just gives insufflation above the IPAP, like about 4 to 5 centimeters above IPAP. The LIAM gives the insufflation pressures, and the other one is the mechanical insufflation device, that is your cough assist. And the most important, I think, tech support that is available. And we have a scoliosis pathway and the aerodigestive unit with the ENT and the pediatric gastroenterologist in place, and the pediatric surgeons. So the take-home message is the financial burden on the family. So the initial cost that the family might have to spend on the BiPAP device or on the rental for the cough assist,
Thank you.
Actually, it decreases the financial burden by decreasing the hospitalization. It also improves the sleep in children, and cough assist helps in preventing hospital admissions, or even shortening the duration of hospital admissions if it's started later. And parents also report, who use it on daily basis, they report that the secretion clearance is better, and that's their motivation to keep using it every day. And there's parental reporting of improvement in quality of life of children who are on BiPAP. With tracheostomy, yes, there is increase in burden of care, but like the first two cases Dr. Eileen presented, I think looking at the development that the child with the SMA
Thank you, Dr. Supriya, and for reinforcing the requirement for intervention with respect to breathing, with respect to coughing, cough assist, and also the support systems that need to be developed. I think anyone working in this field will have to develop a system where we can support the patients 24/7. And I think when I met Dr. Ann 10 years ago, what interested me was that that was something that was missing in, at least in Bangalore, if not across the country. Anyway, I think that is something that the group needs to think of how to provide, because you've got patients as far away as Coimbatore and I don't know where else, supporting all of them.
Assam,
Huh? Yeah, supporting them.
Assam and Siliguri and all of them.
Yeah,
Punjab, Delhi.
supporting them is going to be a huge challenge. I've got a couple of patients, of course, adults on tracheostomy, on home ventilation. Yeah, it is quite a challenge. Uh, but I mean, how often do you think these patients should come for follow-up if they are stable, particularly as this, you can get kids from all over the place. Second thing is, I mean, should we develop support networks in areas in every state, or you know is something that needs to be thought of, because I don't think it's possible. I think while the individual diseases are rare, the actual prevalence is about 30 to 40 per lakh, and that's quite a huge number. It's not, and unless we, like some patients, some physicians have said, okay, we can't do anything and leave it at that. We all know that uh, there's so much that can be done, and a lot of it is doable with a little bit of effort and a little bit of funding. But yeah, and a little bit of support. So, I mean, these are things that we need to think of. That's something that I thought is worth saying. Yeah. Yes, Anne.
Sir, one thing I wanted to add, what struck me while staying in the UK, because I went directly from St. John's after UG, so I was not biased. So when I came back, what struck me was those days there were no expensive drugs. We only had good old-fashioned medical care. Every single patient with SMA2 in the NHS had cough assist. It was just given to them. And what struck me is here, we are struggling. Even those patients who have purchased, I just showed you the graph, we have nearly almost 90 children who have received crores worth of treatment, but only 18 with cough assist. Why are we thinking that we cannot afford it? Because prophylactically, what we realized was many of them, early morning, we tell them when we wake up in the morning, many of us have this habit of taking a deep breath, clearing secretions. If we did that to our children morning and evening, they were less likely to have infections. And when they had infections, we told them use it more frequently, and to each child, a different plan was given. And we're talking about cough assist being expensive. And I'm also struck by the fact that the company that is making the Brias machine is a Mysore based company who had to go away because there was a supply chain problem, and the import duty is so expensive that it has become 4.75 lakhs. Why can't we have engineers and make it cheaper here?
Yeah, I think that's a interesting question. It's only during the COVID that there was a burst of activity where people were thinking of how to make ventilators, etc. And there were a lot of startups, and they all disappeared after the COVID went. Unfortunately, at least a few of them they had hung on, because now with the management of uh, you know chronic respiratory failure, either whether in the pediatric age group or in the adults, and of course, sleep disordered breathing, which is a huge problem. I think we should have our own Maruti cars in this field. I mean, I don't think, but I'm surprised that um, devices are not available in Indian. Indian devices are not available. I'm surprised at that. I mean, I'm sure that that's something that we should look at. We're talking about innovations and things like that, but I think we should look at how we can develop our own
It would
devices.
it would come only if we are pushing for it. We keep telling every
Exactly.
patient that we meet, adult ALS, you need a cough assist. We prescribe it, whether they get it or not. Enough people go and say, I haven't got an ALS, a cough assist. My doctor prescribed, I did not get it.
Yeah. So that is something that we need to look at. Yeah. I
There was
haven't
a
seen any. Yeah. Tell me. You have anything else?
So there are a couple of questions previously. One of them was cough assist young. Dr. Anand has answered. Can it be used for young
Yes.
children? And companies producing it. There was also something about the gene therapy, asking
Yeah.
if that reduces pressures. So we've got around 34 children that we are following up on gene therapy. The pressures do reduce, or the ventilator requirement comes down. But what we are unable to see is the dramatic response that is seen in Western countries. But that is because many of them are given before enough anti Rehon cells die, preemptively. We do not have that luxury. We didn't get to choose our patients. We were given like beggars. We were given, we just gave it. whoever wanted to take it, and informed our families that, you're going to have a chronic burden. This is a disease burden. They were wanting to fight, they fought. But we did see some improvement, quite a lot of improvement in many of them.
Yeah, I think that's something in the future, because probably like so many screening tests are done in the pediatric age group, like thyroid, etc., etc., etc. This is something that is also, as you know, people are going to be more and more able to recognize much early, and hopefully these therapies will be made available to people who require it, and we will be also able to see the same kind of response that you've seen in the Western world. It's just a question of timing. I mean, like you rightly said, it's just a question of timing. When do you give it? After half the anterior all cells have gone, that's all you can save. So I think that's important. The timing is important as to when you should be able to give it.
So one
Yeah.
other point I wanted to add, there was one question about how often you do the monitoring for the DMD. I must confess that I don't think I have ever got any patient whom I have referred for a sleep study who has come back normal.
Because you said to us, and
Yeah, but then we often tell them it is abnormal, but not yet needing intervention. And then we decide this is the interval for follow-up. We are very cognizant of the fact that parents have to shell out 60,000 rupees or 14,000 rupees to do a level 1 sleep study. If we prep the families, when they go to the pulmonologist, they usually have no problem with complying. And like Dr. Island said, many of our patients advocate themselves. While they're in the waiting area, another patient says, oh, my child is getting it, your child doesn't have head control, so you need it. So they take that reinforcement from them. So it makes our work easier. The numbers does make our work easier. And parent support communities really help.
Yeah, I think that's it. So there are no more comments. Then I think we can close. It was a very informative and engaging discussion, and hope those who are not pulmonologists and those who are pulmonologists have both benefited from this discussion. And the way forward, like I said, would be for us to be able to identify patients early requiring ventilation and requiring cough support. I think the cough part of it should be like Anne said, make them take deep breaths and cough right from the day you see them for the first time. You can always decide when to use the cough assist by more objective methods. But this is something that I also was wondering that whether something very simple like the respiratory rate, a pulse oximeter can help parents identify that they're not doing enough for the child, or that the child is getting into trouble, so that they reach medical help much earlier.
There's one last question about exercise
Yeah.
from Dr. Rana L. Gari.
Yeah.
If nobody wants to
There was
answer.
one more question that was on exercise also.
Yeah, the same person
Yeah.
has asked it, reiterated. If
Okay.
nobody wants to answer, may I answer it?
Yeah. Yeah. Please answer.
So exercise is not routinely advocated in muscular dystrophies which are progressive, because it can be harmful. But having said that, there is including the respiratory muscle training. It's such a diverse thing that either physical skeletal muscle or the respiratory muscle per se, there's not enough data. There is an as recent as 2025 paper that says we can't really recommend too heterogeneous a group. So to answer, no. But in the future, this is a wait and watch space, because right now it does, in its present form, it does more harm than good. So for example, neuropathies, we know that 50% sub maximal from 50%, if we do 50% of their strength training, they do improve. But that is only a specific group. If it is not possible to have specialist expertise, it's better to say just don't do. That is the basic conservative management. Do only joint mobility strengths. And that is applicable to even the RMT, the respiratory muscle training. For now, we do not have data for it. I don't know
Yeah.
what are.
They can all be encouraged to become Stephen Hawkins. Okay. If there are no more comments, thank you all very much. I shall close this session, and good night.
thank you. Thank you, sir. Thank you, Dr.
Thank you,
Ann.
sir.
Thank you, Supriya.
Thank you, sir, and thank you, Dr. Saurav, and thank you, ORDI, and
you,
thank
Saurav.
you to Dr. Supriya.
Yeah.
Thank you.
Thank you. Thank you.
Bye.
Bye. Bye. Thank you.
Leave.
Yeah. I'm the first to come and the last to go, kind of thing. Okay, bye.